Study Designs in Pharmacoepidemiology Case Control Study Part 2. Learning Objectives. Understand cases and controls selection process. Selection of cases require case definition. Previously, before the beginning of the study, we need to have the inclusion and exclusion criteria that will formulate our cases. Need for standard diagnostic criteria, we need to identify how the diagnosis is going to be determined. For example, we want to assess our outcome of interest is acute myocardial infarction. How this is defined, okay? Consider severity of disease. For example, asthma. Are we going to include patients who have asthma, or patients with asthma exacerbations, or patients admitted to the hospital due to asthma attacks? This should all be included in the protocol previously, and consider the duration of disease. And this is very, very important if we want to make sure that our exposure occurred before the outcome. We need to assess exactly when the disease or the outcome of interest occurred. Requires eligibility criteria, that's who's eligible, the conditions or the terms of eligibility for the subjects. Sources of cases, two major sources, population-based and hospital-based. Population-based identify and enroll all incident cases from a defined population. So either we go to disease registry, for example, we are interested in cancer, breast cancer or colon cancer, we can go to the cancer registry and get a list of all patients who have colon cancer, or define geographical area. I'm planning to conduct my study in Amman and Erbil, so I search for my data in these areas. Hospital-based, we identify cases where you can find them. This depends on the type of study. For example, hospital, clinics, outpatients, pharmacy, depend on outcome of interest. Let's say I want to assess the adherence of warfarin medications. You can go to cardiology clinics, or you can go to outpatient pharmacies. If the outcome of interest is septic patients, you want to see the predictors of sepsis, the best place is the ICU or hospitalized patient. This is depending on the outcome of interest. Let's move now to a difficult task, which is choosing controls. Selection of controls is more difficult than selection of cases. Controls in general should have a normal or expected level of exposure in the population that give rise to the cases. So there are some issues in comparability to cases. A term for this is called study base. One issue is that controls should be from the same underlying population or study base that give rise to the cases. For example, I want to assess if aspirin and Rey syndrome. So I choose the cases are children admitted to the hospital and have Rey syndrome. The controls should be from the same area, children who live under the same conditions, controls who go to the same hospital, the same schools. It's important to have the controls from the same population base. Need to determine if the control had developed disease, would he or she be included as a case in the study? For example, I want to assess if, for example, for certain infection, let's say influenza. So if a patient had influenza and then he's recovered and becoming disease-free, could this be eligible to be included as control or not? Actually, this type of patient is not eligible. You can't include patients who had the disease and then they cured and became disease-free to be as control. This will introduce bias. Subjects who are controlled, they shouldn't have the disease in the time frame you are asking or you're looking for. Again, controls will have the same eligibility criteria as the cases. Source of controls, both population and hospital. Population-based controls IDL represent exposure distribution in general population. You can identify the list by driver license list, Medicare, par recipient, depends on anything you have to identify these subjects. But if low participation rate, this will lead to response bias or selection bias, which means there is a reason that led that more patients are choose to be are included in cases, but it's hard for us to find controls. Why? Maybe there is a selection bias in our sample. Source of controls also, the hospital is a great place. And actually, in many cases, hospital based controls are have more advantages. These advantages include first one, similar to cases, because they also are sick patients who need help, and they have the same socioeconomic status, the same geographical location, more likely to participate. In many of the studies, sick patients are more likely to participate in clinical studies compared to healthy patients. Efficient because you can see the patients, you can talk to the patients, you have their medical records, you can look at any previous data that you need. Disadvantages, again, if they have the disease or if they are in a borderline stages of the disease. So, for example, I'm looking for a relationship between asthma and lung cancer, and my controls have COPD. COPD is in somehow cannot be differentiated and have the same pathophysiology as asthma. So be careful when choosing your other sources of control, relatives, neighbors, friend of cases. Advantages, they are similar to cases, the same socioeconomic status, the same educational level, the same neighborhood or geographical area. Usually, they are more willing to cooperate. Disadvantages, more time consuming, and may have similar risk factors like smoking, alcohol consumption, or other things.